front, because remember, a lot of these are curettings and biopsies. So let me put that out there right up in front. I think it's important to remember. So back to this specimen, just a very low power. This is probably a toe. This crud on top, this blue stuff, is the ulcer, and then you can see underlying bone here. Here's another piece of bone, and this time around, you can see this layer of cartilage. This is articular hyaline cartilage. I remember I asked you guys this question before. Is this lamella bone or is this open bone? Someone want to help me? What do you think this is?
Lamellar bone, sir.
Very good. So beautiful lamellae, right? And then these are osteocyte nuclei. And remember, these osteocytes are in a space, a big Cabrera space, and you have small dark nuclei, and they are scattered throughout. If you look here, there's a lot more osteocyte nuclei, and that's because this bone is relatively new. It isn't as new as what I would call woven bone, but it is new bone. And the reason I say that is, one, is there's a lot more osteocyte nuclei. So this is the kind of cellularity. This is more mature bone where you can see beautiful lamellae. If you look here, you see some lamellae, but they're not very well organized. And it's as if this has been growing in different layers. So this layer looks different from this layer. So this is more newer bone, which is why it's a little more cellular. And you can see that there are seams of bone. So this is a seam, here's a seam. And so these different pieces of bone have been sort of laid on at different points of time. And I refer to this as remodeling. The osteoblasts are actually not very well represented. As the bone matures, the osteoblasts shrivel up, and perhaps that's an osteoblast. They become very small. This is bone, which you can see is still sort of growing, which is why you can see the osteoblasts, but you're not seeing them in their full glory. All right, so that's to do with the bone. And I wanted to show you, to just talk a little bit about woven bone as well. Okay. So this is also case one. So this time I wanted to show you this. Let's go to full screen. Right, so this is more traditional woven bone. You see that? So this is lamella bone here, although it's hard to see the lamellae, but you can see the ends of the lamella bone here. This is woven bone, and you can see it's very different. The osteocytes almost look like osteoblasts. In fact, the osteoblasts get embedded in the bone and get converted into osteocytes. So you can see these cells have a lot more cytoplasm. They almost have this eccentric cytoplasm that is associated with osteoblasts. They almost look like plasma cells, don't they? And you can see that it's woven bone, sort of loosely, almost a little lace-like deposition with absolutely no lamella bone. Here along this side, you see more prominent osteoblasts. And the one thing you'll notice is that most of the woven bone, in fact, all of the woven bone gets deposited. I don't know, I'm just getting all these warnings. Okay, turn off virtual background. That sounds good. Looks like my computer doesn't have enough memory. To tell you the truth, I don't have enough memory either anymore. So new bone gets generally deposited on the surface of old bone. So it's like a scaffold. For new bone to be deposited, it requires the presence of pre-existing bone. So that it uses the pre-existing bone as struts, and then new bone gets deposited around it. I also wanted to show you these beautiful osteoblasts. This is what osteoblasts look like. A classic osteoblast is a plasmacytoid cell, nucleus on one side, cytoplasm on the other side. Looks like a plasma cell, except it's not a plasma cell. Right? Okay. So there's marrow here. Let's go back to case one and talk a little bit about articular hyaline cartilage. So here's articular hyaline cartilage. Right, so these are chondrocyte nuclei, the articular hyaline cartilage. We talked about other forms of cartilage. We talked about fibrocartilage last time. Hyaline cartilage looks like very homogeneous, very glassy. This is the tide mark, which is sort of the barrier between, or the line between the cartilage and the underlying bone, which I refer to often as subchondral bone. And then sort of to go back to this case, there's really not a lot to talk about, except that there's osteomyelitis here, right? So these are neutrophils. These are dying neutrophils, which is what often happens with osteomyelitis. And to make a diagnosis of osteomyelitis, there's a very nice interview I did with a very well-known pathologist from the Cleveland Clinic called Scott Kilpatrick. And he wrote a very nice review in the Journal of Clinical Pathology. And it was about non-neoplastic bone. And I was asking him some very pointed questions about non-neoplastic bone pathology that a lot of people are not interested in, but is the bulk of what we see in clinical practice, at least in the US. I was asking him about how do you make a diagnosis of osteomyelitis? And we agreed that there has to be inflammation, ideally acute, but it could also be chronic. But then the bone has to react to it in some way, right? So here you can see the bone is dying. You can see there are no osteocyte nuclei. We'll talk a little bit about how do you tell between artifactual loss of osteocytes and true dead bone. But take for me right now that the bone is reacting, the bone is dying. You can see how irregular the bone is as well. So the bone is reacting. And the third thing he wants, and I think it makes sense, it has to be in a clinical context. The clinical findings have to be suspicious or concerning for acute osteomyelitis. Like all of pathology, you cannot operate in a clinical vacuum. Now, there's certain situations you can. So, if you have an invasive squamous cell carcinoma, you don't really require someone to tell you if it's obvious that it's, you don't absolutely need the clinical context. But in most cases, you do not operate outside the clinical context. When you do, you will go wrong more often than not. The other thing is you can see that the chondrocyte nuclei have dropped out here, which means that the articular cartilage is also dead. Remember, the articular cartilage depends, there are no blood vessels in the articular cartilage. It almost entirely depends on the synovial fluid for nourishment. So you take that out, the articular cartilage dies. So that's about, what I was trying to do there is talk about normal histology, lamellar bone, woven bone, the differences, osteocytes, osteoblasts, and we'll see some osteoclasts as we go along, articular hyaline cartilage, and I showed you this case, which is acute osteomyelitis. So now let's actually go to a real case, and what I'm going to do is I'm going to start by showing you some radiology images. So I don't always do that consistently, and that's because in the interest of time, but believe me, none of us would even dream of signing out bone without having, and I think the other thing, you can't you are dependent on the radiologist, but you shouldn't wash your hands and say, oh, this has nothing to do with me, because I think if you are to practice bone pathology, you must know at least something about imaging, right? So you must know the very basics. I'm not asking, and nor am I expert radiologist, but I do think you do need to understand, at least to the extent that you can communicate with the surgeon. You need to learn the language. So this was a youngish man, and you can see somebody's drawn some line, and that's because there seems to be some very ill-defined lesion in the distal end of the femur. So this person was in their 20s. This is an AP view, and I really don't see anything, and I believe not much was made of this. And then this patient comes back 3 years or 4 years later, and now there's something really interesting going on, right? There is this cloud-like calcification, which appears to be centered on the posterior aspect of the femur. The cortex, by and large, seems intact, although it seems to somewhat thicken. So you'll be able to tell if you're an expert radiologist. And I'm not really a radiologist, but I can see that mass. I can see a slightly thickened cortex compared to what's more proximally. And here's an AP view, and it almost looks like this cloud-like calcification, which is stuck on the surface of the distal end of femur, right? Here's the CT scan, and you can see this is, I think in general, CT scans are much easier to interpret than plain films because you're seeing a single slice of the tumor. And here's the distal femur, and you can see this big calcific mass. This has got to be some sort of a tumor. In fact, it turns out to be a pretty classic phenotype of a bone-forming tumor. Here's the, I believe this was the T1 image. There's something going on in the marrow. So that much of that could be edema, but I think what is most prominent is this big mass on the posterior surface of the femur, right? So with that, we'll go back to, he already made a diagnosis, right? So this is really a great example of the fact that the surgeon already knows what's going on, right? So yeah, there I see it now. So what kind of osteosarcoma, Neha? It's a very specific kind of an osteosarcoma.
Yeah.
Parosteal, very good.
Okay.
Thank you, Dr. Neha Sheikh. There, Dr. Devang Shah tells me it's parosteal. Very good, guys. Yes. So you better know because so I think a lot of us operate on the belief that our clinicians don't know much. Believe me, the orthopedic surgeons know what they're talking about, right? So if you I think so. For example, so this is a parosteal osteosarcoma, but if for the unwary pathologist, I'm reading your comments. It's nice that they're actually popping up on my screen. So thank you for your thoughts. So keep sending me your comments, and I'll just read a few of them out as I go along. They appear on the right corner of my screen. So to the unwary pathologist who has not seen this imaging, you know what they would call this? They would call this fibrous dysplasia. The reason why radiology becomes so important, so fibrous dysplasia is bone and bland-looking fibrous tissue. This could be mistaken for fibrous dysplasia, but fibrous dysplasia is an intraosseous lesion. When you look at that imaging, it's sitting outside. So you don't have to be a radiologist. It's sitting outside the bone. That rules out fibrous dysplasia. Boom, that's gone, right? So just based on the imaging alone, it's not fibrous dysplasia. So you're worried now, right? This is not fibrous dysplasia. But what is interesting about parosteal osteosarcomas is that they can be very, very bland. So let's look at them under very low power. So this was the mass, right? This was the mass sticking out. This is a resection. Believe me, the biopsy was really, really hard. One of the things that really helps on a biopsy is an immunohistochemical stain for MDM2. The MDM2 is amplified, and we use immunohistochemistry as a surrogate marker for the amplification. So the gold standard is always FISH, but immunohistochemistry works just as well in most instances. Parosteal osteosarcoma and well-differentiated osteosarcomas are two types of osteosarcomas where you do see MDM2 amplification. So what we got on a biopsy was a very small area like this, and we weren't sure it was malignant, just a little bit of bone and a little bit of fibrous tissue. And because we could demonstrate MDM2, we called it a parosteal osteosarcoma, of course, with the radiologist. So Carrie Henselman, my surgeon, told me, I think this is a parosteal osteosarcoma. And the radiologist told me that it's a parosteal osteosarcoma, and now I'm happy. So this is not fibrous dysplasia because you can see the bone and the fibrous tissue is infiltrating into the soft tissue here, right? So this is fat. You can see the tumor streaming out. Fibrous dysplasia would never, ever do that. When you look at this on high power, some parosteal osteosarcomas can be very, very bland looking. So just imagine, right, these cells, right, with a lot of collagen, and you might say, this is just scar tissue or whatever. And this is very typical of parosteal osteosarcomas. Most parosteal osteosarcomas are grade 1. Before we go there, so the parosteal osteosarcoma, there are two histological parts to it. One is the fibrous tissue, and then, of course, is the bone. The presence of bone defines this as an osteosarcoma. No bone formation, you cannot make a diagnosis of osteosarcoma. But in most cases of high-grade or conventional osteosarcoma, you'll see delicate, lacy network like osteoid. In parosteal osteosarcoma, you see these thick, fat, there's no other way I can characterize this. I know fat is a pejorative term, but a thick, fat layers of bone. And to add to that, in most conventional osteosarcomas, you see woven bone, right? In parosteal osteosarcomas, what's really interesting is that you see some lamellar bone, right? So the mere presence of lamellar bone does not rule out an osteosarcoma. So well-differentiated osteosarcomas, which is an intraosseous entity, and parosteal osteosarcomas, which is a surface thing, both of them could be associated with lamellar bones, and that's something really important to realize. So when you look at lamellar bone, a little bit of fibrous tissue, you might mistake this for a benign process, but on imaging, it would be completely different. The other thing I want to point out to you is that, it depends on where you're coming from. To my eye, this atypia is very significant, but I can see, and in my younger days, I certainly had this problem. I would look at this and say, but that doesn't look obviously like cancer. But in the context of radiology, this is very, very atypical. In fact, this is too atypical even for fibrous dysplasia. And by atypical, I mean the cells are larger and more hyperchromatic. Although if you're a beginner, you will see that it's, you don't have a reference in terms of what is benign and what is malignant. And I remember when I was training very early on, people would say, oh, this is atypical, this is malignant, and they wouldn't give me a detailed explanation as to precisely what is atypical, right? So I was trying to do a little bit of that. But it's for you, but it is hard. Talking about parosteal osteosarcomas, sometimes you can have a cartilaginous cap. This particular one does not have a cartilaginous cap. Let's see, somebody's texting me. Sorry. This one does not have a cartilaginous cap. What is interesting about this particular case is that there was, and I was trying to find the growth, unfortunately. If you remember one of the very first x-rays I showed you, and the MRI, there was some intralesional, intramedullary component to it. By the way, just to orient you, this is articular hyaline cartilage, right? And if you look at this, you'll see a lot of the osteocyte nuclei have dropped out. And this is an artifactual phenomenon. This is because of over-decalcification. We'll answer your questions. Why don't we answer some questions at the end of this case. So the osteocyte nuclei here is dropped out because of over-decalcification. You can imagine to decalcify this piece of bone, it took quite some time. And by the time we submitted sections, it was over-decalcified, and a lot of the osteocyte nuclei have eventually dropped out. I know this is not osteonecrosis because the soft tissue is alive. One of the first things to do when the bone dies is that the marrow dies, and the marrow to me looks alive with adipocyte nuclei, among other things. So what I was trying to get back at is the parosteal osteosarcomas are generally on the surface and stay on the surface. This particular one infiltrated the adjacent bone. And this is what a well-differentiated osteosarcoma looks like. So again, big, thick seams of bone and those atypical cells. Now remember, the important thing about the diagnosis of an osteosarcoma is this is one of those osteosarcomas, along with well-differentiated osteosarcomas, that do not require additional chemotherapy unless they dedifferentiate, unless they become higher grade, right? So the great thing about this case is that resection, the margins were negative, patient's done. This will not metastasize, right? So parosteal osteosarcoma with extension into the intramedullary bone, which can happen. I haven't seen it very commonly, but it was a beautiful gross picture that unfortunately I could not find this morning. By the way, this is some very nice storiform pattern here, which can happen with these parosteal osteosarcomas. Case 3, right? And I just wanted to talk about this very quickly. This is a hip. This is articular hyaline cartilage. We've talked a lot about this. This is subchondral bone. This is cancellous bone or medullary bone. And I wanted to show you this area. If you look here, this is avascular necrosis. And I wanted to show you what dead bone looks like. Dead bone, not only that you have no osteocyte nuclei here, so this is pre-existing or lamellar bone where all the osteocyte nuclei have dropped out, but you can also see necrosis in the marrow. So this is fat necrosis, and the bluishness is because of calcification. Often calcification is deposited on fat necrosis. So this is typical avascular necrosis, and you can draw a single line. Ignore these dots here. I have no idea why these appeared. See one of my residents trying to point out something. So this is the interface between dead and alive. And if you look at this, the cartilage is sort of lifted off. This is not an artifact. This is really what happens, because when the bone dies, the articular cartilage sort of breaks off and then floats off. It can even float off into the joint, forming loose bodies. The cartilage, interestingly enough, even though it's floated off, is still alive because the cartilage is nourished by the synovium and not from underlying blood vessels. Let's go to case number 4. Here's another typical example. Yeah. Okay, so this is a beautiful example. Does someone want to describe this for me? This is case 4. So I'll tell you the story. This was a really fascinating story. This woman, this was in the hand, and I forget lunate bone or one of the small bones of the hand. It was eventually resected. But she went around for almost a decade with pain in the hand. And I don't know what happened, but she had at least 3 surgeries of the hand, none of which addressed the bone lesion. Either the bone lesion was not seen or it was ignored. And eventually somebody figured this out. A lesion here. Right, just to orient you, this is articular hyaline cartilage. Oh, and I did want to point out this. Does anyone know what this is? So you see this bone here, and then you see these chondrocyte-like nuclei, right? These look like chondrocytes, don't they, right? Space, nucleus, and then there's more collagen, like dense collagen tissue. Does anyone know what this structure is? So this is a tendinoligamentous insertion site. So when tendons insert into the bone, right? So the tendon has to go and attach to the bone. That interface of the tendon attaching to the bone is composed of fibrocartilage. So this is typical fibrocartilage, right? This is not hyaline cartilage. And this, you'll see this very, very frequently. And this, of course, is more prominent because there's a lot of degenerative change as well. I mean, an older individual with degenerative change. Okay, so articular hyaline cartilage, your tide mark, and this is the lesion. Anyone know what this is? This is no tricks here. Pretty straightforward. Come on. One of you. Yay! Osteoma. Thank you. That's very helpful. Okay. Chondroblastoma is a good option. We can talk about why this is not a chondroblastoma. Osteoma, I wouldn't agree with osteoma because osteoma is a surface lesion, right? So osteoid osteoma. This is an osteoid osteoma. What was interesting is that this is an articular osteoid osteoma, and most osteoid osteomas, you're right, so they're less than 2 centimeters in size. Most osteoid osteomas are intracortical, right? In the diaphyseal or metaphyseal, or sometimes in the diaphyseal location. They're generally not intra-articular, so this was an intra-articular osteoid osteoma that mimicked arthritis. This person was felt to have some sort of an arthritis, some sort of a tendinopathy when it was just an osteoma. So these patients have this very typical history, pain at night, relieved by NSAIDs, typically in the second decade of life. We almost never see resections because we burn them, so we'll biopsy them, and then the radiologists are so confident that they'll biopsy them, and they'll use thermal energy to ablate them. In the old days, they used to curette them out, they used to resect them. And we do resect some of them, as you can see in the hand, because I think they felt that they couldn't ablate this because the nerves were too close by, etc., etc. That chicken wire, it's an interesting one. I don't know, I don't remember chickens in India, but chickens, no, I'm just kidding. This is too fat to be chicken wire. All right, so let's go to the lesion. The first thing you'll notice is that it's very well circumscribed, right? Remember, if it's infiltrated, it's probably malignant. If it's circumscribed, it could be benign, it could be malignant, but you're thinking more benign. The second thing you see is that it is bone forming, right? So you're thinking of a bone forming tumor. There are not that many bone forming tumors, but they're classic bone forming tumors, and then there are other tumors that can produce a little bit of bone. So, for example, if you think of a giant cell tumor, you're not thinking of a bone-forming tumor, but I can guarantee you that you'll see a little bit of bone in a giant cell tumor. And if you treat that patient with denosumab, we wrote this paper many years ago, you'll have an explosion of bone formation. So giant cell tumors can produce bone. But the classic bone formation, somebody suggested a diagnosis of osteoma. Osteoma is a surface lesion, right? It's stuck on the surface. If it's intramedullary, it's not an osteoma. The second one is an osteoid osteoma, an osteoblastoma, and someone very helpfully pointed out the difference between the two is simply size. And then there's only one malignant bone-forming tumor, and that is osteosarcoma, right? There are other instances where you can have malignant bone formation, but we won't talk about that right now. Somebody asked me if this was chicken wire. It's not chicken wire-ish. So chicken wire actually separates individual neoplastic cells, right? So it'll be between the cells. These are sort of thickish seams of bone, not as thick as we saw in the parosteal osteosarcoma, but still thickish, right? And this is fairly typical of an osteoid osteoma. So you'll have these seams of bone, and then if you look in between, the cells surrounding this look like osteoblasts, don't they? So generally, when you see osteoblasts around bone, you are not dealing with an osteosarcoma. There is an osteoblastoma like osteosarcoma, but those are as rare as hen's teeth, and unless you have very bad karma, you won't see one of those. So these are osteoblasts, which makes me feel good that they're probably dealing with a benign process. There are actually a few osteoclast-type giant cells. Here's probably one. They aren't really very pretty, but here's a nice one. Here's a nice osteoclast-type giant cell. And then this very loose stroma, right? If you were to use immunohistochemistry, you would use FOS and FOSP, but you don't need that. This is a very classic lesion. And then you can see parts of these are more ossified, and there is more normalization of the nuclei. In other areas, you have bigger seams of bone. So this is a very classic osteoid osteoma. Manish, you wanted to add something to that?
I guess.
Do you guys typically burn them?
Yeah. So we do RFA only for most of them, and nowadays we don't biopsy them also. It's more or less a radiological diagnosis, and we rarely biopsy an osteoid osteoma nowadays.
Right. I mean, we get a biopsy at the same time as the ablation.
Yeah.
And frequently the biopsy will miss the, I should say frequently, but occasionally it'll miss the lesion, but it doesn't really matter because, the imaging is so characteristic and the clinical picture is very characteristic. Okay, let's go to a more challenging case. Let's go to case 5. Wait. Okay, here we go. Okay, so wait, for case 5, I have an imaging. So this is a very recent case. Well, it was somewhat troublesome. I think this was a middle-aged man or a woman. And, okay, so this is where my knowledge of imaging sort of starts fading. But there's clearly a lesion here, right, in the metacarpal bone, in the diaphysis, and you can see some irregularity of the cortex. Perhaps there's a little bit of mineralization, but I think it becomes more obvious. I can't remember. This was probably a stir or something like that. But it's clear that there is an intralesional component, and then there's this more bright extraosseous component, right? And here's a T1 where you can see it again, right? So it's much more darker, but you can again see this intramedullary component and then the soft tissue component around it. And the surgeon was, I don't know, our surgeon and radiologist, I think, scared me a lot on this case. They were very concerned about Ewing's. Makes sense in some ways. And so when I looked at this, well, I'll let you guys talk about this. Back. Said, could this be Ewing's? Does anyone think this is Ewing's?
So on radiology, sir, I think everyone will be concerned with this case because this looks like a permeative destruction with soft tissue component.
Right.
So I think everyone will be concerned for this case. Yeah. So we can discuss, but yes, no matrix. So I think it's concerned.
Yeah. No, that was the concern, right? So, and of course, when you have difficult cases like this, it's always a VIP patient, right? So everyone and their mother was sort of frantically calling, and so I agree. So I think I can see folks saying that it's not Ewing's. I agree with you. Ewing's is a round cell tumor, very cellular. All we are seeing here is these bland spindle-shaped cells and these osteoclast-type giant cells, right? And so a lot of people have seen a giant cell tumor, but I did want to show you this area where there was bone production. You see that? And that sort of got us worried. Oh, could be because the imaging was concerning, and now we're seeing bone, and we're wondering whether this is an osteosarcoma. So now we have a differential diagnosis, right? We have imaging, which is concerning, as Manish said. We have histology, which is driving us. These are clearly osteoclast-type giant cells, and they're mononuclear cells. And to make a diagnosis of a giant cell tumor, it's often said that the mononuclear cells should look like the nuclei in the giant cells. Whether that helps or not is another story. I personally don't find it very helpful. But certainly there are areas like this that look like a giant cell tumor. What do I mean by that? Diffusely distributed osteoclasts, almost evenly distributed throughout. Ignore this area, right? This is just a little bit of hemorrhage, perhaps some of that was procedural, but evenly distributed osteoclast-type giant cells, which I remember the non-neoplastic cells, and then these plump mononuclear cells with those little nucleoli. So a giant cell tumor was the first thing we thought of. In fact, these areas look very much like giant cell tumors. We know that giant cell tumors can produce a little bit of bone, but I was still worried at the back of my head that this is could be a malignant process. And this is actually very typical of giant cell tumor. You see these osteoclast-type giant cells, they have more nuclei than you can count. So 50, 100 nuclei, really big, juicy giant cells. It's very typical of a giant cell tumor of bone. So we did some immunohistochemistry. What do you think we did? When I put it on the chat box, giant cell rich osteosarcoma here, that's what I was worried about, whoever that was.
So
E34W, it's a H3.3, so it's a histone modification. Sorry, go ahead, Manish.
Yeah, so GCT, sir, the rule is GCT must be subchondral.
Yeah.
So a giant cell
Location
tumor of
doesn't fit.
bone, so and this is not subchondral.
Correct.
So I think we can do histone food for GCT because you are seeing predominantly giant cell, but radiologically this is not a giant cell tumor. Yeah, it can be
Exactly.
one of
So-
the mimic of giant cell tumor, but it's not a giant cell tumor.
And so we were really worried, could this be a giant cell rich osteosarcoma? And that's the thing that really bothered me. So you're right, so G34W, it was negative. So what did I do next?
Alkaline phosphatase.
Yeah, but you mean like,
So sometimes like this Brown tumor kind of a picture can also confuse us because
right.
Yeah.
So a brown tumor, that's a very good differential diagnosis. And I did ask, there were no other lesions elsewhere, and I can't remember what the alkaline phosphatase was.
That's fine if there are no other
We
lesions.
certainly have seen some. I saw we had a recent case of a brown tumor. I haven't seen one in a long time. You know, untreated uh, hyperparathyroidism has become very uncommon. So I think we don't see very much in terms of giant cell tumor, a brown tumor. So we did a USB6, and we sent for USB6 fish, and there was a rearrangement of USB6. Now, does someone have a suggestion?
And it's ABC, sir.
Right. So this was a solid ABC. It's just a challenging one, but that's what we eventually called it, as a solid ABC, and that's on the differential. So giant cell tumor of bone, solid ABC, brown tumor. So we covered a giant cell rich osteosarcoma. That's the differential diagnosis. Is there something else I missed? Anyone can think of someone's cheering. I'm not sure. I think Manish, they're cheering for you. All right, so and so you can see a fair amount of bone in an ABC. So another bone forming, another neoplasm that you don't generally consider a bone forming tumor, but you can see a fair amount of bone. Shushma has some. I see. I have very little experience with those markers, except that I would say I'm not a great believer in SAPB2. No, I mean I know across the street. So the Brigham is across the street from us. I mean, literally, I can throw a stone and break down one of the windows of my colleagues at the Brigham, although we are rivals, of course. But they are great believers in SACP too. I'm going to get myself into trouble if I talk too much about the Brigham.
So, sir, US positivity in ABC is only in around 70% of cases.
Correct.
So, not in all. So, was there any other feature suggestive of ABC here? Because if the USP6 would have come negative, would you have still pointed an
I
ABC?
think we would have been less definitive one, but we didn't really have an alternative diagnosis, and it sort of fit the solid ABCs. Or some people use the word giant cell reparative granuloma, what we used to call in the hands and feet, giant cell reparative granuloma.
Yeah.
I think the morphology was quite consistent with that. And as you saw, I mean, we ruled out a giant cell tumor of bone,
Yes.
we ruled out an osteosarcoma, and what we were left with is then a solid ABC. I mean, at the end of the day, you and I know that, it doesn't make a huge difference as long as it's benign. So they went and curated it, and it was the patient's been fine. Sometimes we spend. Someone mute their device. There's an unusual humming sound coming out. Can you guys mute your device? Thank you. Sometimes it doesn't really matter what you call it, as long as you call it benign. I remember signing out with one of my, was the head of pathology at Ames. I did a residency in Ames with Dr. Gujral. And our HOD was UN Bhuya, was a renal pathologist and I was signing out with him as a senior resident. And I asked him, what should I call this? And he said, call it whatever, just don't call it malignant, So at the end of the day, what you really need to do is to distinguish between benign and malignant. Putting names on it is sort of sometimes just the icing on the cake. Here's a phenomenal case, right? It's bone forming. I forget, what case number is this? Can someone remind me? Case number 6. Anyone have a diagnosis? You want to put it in the chat box? Because I know you guys are so shy to speak up. Our residents here are like, just, you know, want to be spoken, want to be recognized.
In this, so may I?
Yeah, very good, Neha, very good. Yes. So somebody asked me for location. You know, I have a good colleague of mine who says it is wherever you want it to be, right? And by that we mean some things are histologically so characteristic that you don't necessarily need a lot of clinical information. That's one, which is sort of contrary to what I said earlier, but you know, we can clarify this a little later. But the other thing is that you know, when you initially look at the slide, and that's a very good diagnosis, Shrishma. When you initially look at the slide, I think you should look at it unbiased. I think there are there's broadly two ways of doing this, right? You can do it in a biased way, where you identify all of the information, you look at the imaging, and then look at the slide. My suggestion to you is always look at the slides in an unbiased fashion, then come back and look at the imaging, then come back and look at the clinical history. Because if you do it the other way around, you carry a lot more bias. So you're as biased as Manish here, right? So you know what it is clinically, and you want to fit the histology in. If Manish was a pathologist, of course. But you know, if you look at it without bias, it's somewhat more helpful. But I saw that diagnosis, but this was actually in the soft tissue. This was a big soft tissue mass in the thigh, and this is indeed myositis ossificans. Very good. So this is, and the diagnosis of myositis ossificans, there's one feature that is the most helpful feature that's very much here. Does anyone know what that feature I'm looking for to make a diagnosis of myositis ossificans? You can put it in the chat. Zones, yes, the zonation, yes. Zonation or maturation. That is the center. Thank you, Dr. Datta. That was very helpful. So the zones are the cellular zone, the maturing zone, and the most mature bone. And by that, you see no bone formation or very immature bone, a little bit of immature bone, and then more mature bone at the periphery. And this is just a beautiful example of this. But I can tell you where things can go wrong, right? So you can go here and say, gosh, oh, snap. If you go down a very high power here in the center of the most immature component, you might mistakenly call this an osteosarcoma. And believe me, I have seen at least half a dozen examples, even in the last 5 years, of myositis ossificans being called osteosarcoma. And this isn't the worst example. This, in fact, was resected several months after it was detected. So the initial phase is the most cellular. This is matured out, and this is less scary. But this is certainly something you think of. The radiologist may not be able to help you, particularly if there's not a lot of ossification. But the one thing I'll tell you here is obvious bone, right? And you might say, oh, this is a typical cell surrounding the bone. This is osteosarcoma. But look at these cells surrounding the bone, osteoblasts. So that's a rule that you can take to the bank with you. That is, if you see bone surrounded by osteoblasts, you're probably not dealing with an osteosarcoma. Again, on the biopsy itself, you may be lucky to see a little bit of zonation. This is the most immature amount. This is actually beautiful storiform type pattern. There's cysts here as well. I heard somebody mention the word cyst. You can see very nice osteoblastic rimming here, right? That means that it's probably not an osteosarcoma. And as you march outside, it's still quite cellular here, right? But some of the cellularity is driven by inflammatory cells. There are scattered osteoclast-type giant cells. And as you go further and further away, now you're seeing almost mature lamellar bone, right? This makes you feel a lot more confident that you're dealing with myositis ossificans. You see the same USB6 fusion in these cases as well. So if you're not sure, try USB6 fish before calling it an osteosarcoma. I can't tell you the number of cases. This is, again, look at that, right? So you look at that, it looks like immature bone surrounded by these very immature progenitor cells. This is very immature bone. The osteoblasts are not well developed, so these are more bone precursors, osteogenic precursor cells. And so someone could look at this and call it osteosarcoma, but even this, the most immature component, you see it has a slightly Roman arch-like configuration. It's just far more organized than an osteosarcoma. Osteosarcomas, the bone is distributed in a very random fashion. Here's more of that sort of immature bone with these osteogenic precursor cells. But it's that low power, that zonation, that is very, very typical. Let's see. I think so. Case 7 is, I think, the hardest of the lot, right? And in the interest of time, I'll just go ahead and speak about it. Does anyone have a diagnosis? You can put it in the chat box. I'm curious if somebody looked at these slides and has a diagnosis. I'll give you a moment before I start talking. I can tell you that the radiology was a very aggressive lesion. This was a proximal humerus lesion in a 70-year-old something patient. So enchondroma, chondrosarcoma, fibroblastic osteosarcoma. I think you're all right. There's no one wrong. I think it's a bit of everything. Chondrosarcoma. There is encasement. I agree with you. So, the weird thing is that no one's wrong here. It's like that story of the elephant, right? It depends on what you're looking at, right? So this is an enchondroma, right? So you can see this is very low grade. This is cartilage, chondrocyte nuclei. There's calcification. So there's the enchondroma. Then we will find areas that look cartilage that looks much more malignant. So I don't care if there's encasement or not in this case. And I know everyone's looking for entrapment, encasement, infiltration. But this is cartilage, right? They're chondrocyte nuclei. This is way too cellular. Ignore the osteoclast-type giant cells at the periphery for a moment. Just look at this. This is too cellular. This is myxoid. The nuclei are no longer lymphocyte-like. This is grade 2 chondrosarcoma until proven otherwise. I don't care what the surgeon tells me, what the radiologist tells me. This is way too atypical. The only thing this could be is a chordoma, right? But remember what I said about chordomas last time. Chordoma cells stick to one another. Look at these chondrosarcoma cells. They're sort of putting out their hands, just touching one another. They're not sticking to one another. Anyway, this isn't the humerus, so I shouldn't really be thinking of a chordoma in the first place. Although we have seen chordomas in weird places. I guess the other possibility you should think of is an EHE, but this is it is epithelial hemangioendothelioma, but this is a little too myxoid for that. Okay, so we have reached an enchondroma and a chondrosarcoma, so perhaps this chondrosarcoma arose in an enchondroma, right? Actually, a lot of chondrosarcomas arise in the background. But there's something, a background of a chondroma. But there's something even more interesting about this. Do you think this is going on here? I know a lot of this is dying, but this is this chicken wire calcification, necrosis in the background. This is an osteosarcoma. So this is a dedifferentiated chondrosarcoma with osteosarcomatous differentiation. This is one situation when you see malignant bone, you do not call this an osteosarcoma. So this is a dedifferentiated chondrosarcoma. This is one of the most malignant bones, malignant neoplasms in bone pathology. You almost never see them survive. They almost never survive beyond 2 years unless they're very, very small. They are resistant to chemotherapy. And so there's a huge difference between, and whether there is osteosarcomatic differentiation or not really doesn't matter. Once you have a dedifferentiated component, that's pretty much the end of the story. There are other pieces of bone here which are completely reactive, and I wanted to point that out to you. So look at that, and this is osteoblastic rimming. So this is the result of a fracture. And in fact, on other sections, there was evidence of a fracture callus. And that may be just a fracture callus. Somebody seeing entrapment may be seeing a fracture callus. So there was a fracture callus because there was a fracture. There was enchondroma, that's the low-grade component. Then there was the high-grade component. And then there's osteosarcomatic differentiation. Does anyone know, for a bonus question, how do you distinguish between a molecularly between a dedifferentiated chondrosarcoma producing bone and an osteosarcoma? A molecular test to distinguish dedifferentiated chondrosarcoma from osteosarcoma. You can sequence for IDH1 or IDH2. So we had a paper many, many years ago. Subsequently, there have been a lot of papers. IDH1 and IDH2 are, or IDH2, actually it's or IDH2 are detected in between 50 and 60% of chondrosarcomas. So the absence doesn't mean a whole lot, but the presence does. All right, so any last minute questions before I hand podium to Manish?